Good morning, nursing students. Today we are covering anatomy, chapter 17 in my book, which is Understanding Anatomy and Physiology, the second edition by Gale Sloan Thompson. This is the respiratory system. So, oxygen, first of all, the respiratory system. During a 24-hour period, the average person will breathe 23,040 times. Well, that's a lot. Oxygen plays a powerful role in overall health and well-being. Most metabolic processes of the body, including the digestion of food, the fighting of infection and disease, and the production of energy, depend on oxygen. Your ability to think, feel, and act depend upon the availability of oxygen. The respiratory and cardiovascular systems work closely together to provide the body with oxygen and to remove carbon dioxide. The respiratory system assumes other roles as well. It influences sound production and speech. It makes the sense of smell and therefore taste possible. And as will be discussed in chapter 19, it helps the body maintain homeostasis through the regulation of acid-base balance. The respiratory system is divided into two tracts. Fast fact, you can live about 40 days without food, 3 to 5 days without water, but only minutes without oxygen. So the upper tract and the lower tract are shown here. Functionally, the respiratory system also includes the oral cavity, rib cage, respiratory muscles, including the diaphragm. The structures of the upper respiratory tract, consisting of the nose, nasopharynx, oropharynx, laryngopharynx, and larynx, warm and humidify inspired air. They're also responsible for the senses of smell and taste, as well as swallowing food. Fast fact, obstructive sleep apnea occurs when the muscles supporting the soft palate and the uvula relax, allowing those structures to fall back and obstruct the airway. Nose and nasal cavities. Air enters and leaves the respiratory system through the nose. Just inside the nostrils are small hairs called cilia that filter out dust and large foreign particles. The nasal cavity lies just over the mouth, separated from that orifice by a bony structure called the palate. A vertical plate of bone and cartilage called the septum separates the cavity into two halves. The cavity is lined with epithelium rich in goblet cells that produce mucus. Pharynx, just behind the nasal and oral cavities, is a muscular tube called the pharynx. Commonly called the throat, the pharynx can be divided into three regions, shown here. The nasopharynx extends from the posterior nares to the soft palate. It contains openings for the right and left auditory eustachian tubes for hearing. The oropharynx is a space between the soft palate and the base of the tongue. It contains the palatine tonsils, the ones most commonly removed by tonsillectomy, as well as the lingual tonsils found at the base of the tongue. The laryngopharynx passes dorsal to the larynx and connects to the esophagus. Our body at work. Only air passes through the nasopharynx, while both food and air pass through the oropharynx and the laryngopharynx. Larynx, this is on page 339, lying between the root of the tongue and the upper end of the trachea, the larynx is a chamber formed by walls of cartilage and muscle. Because it contains the vocal cords, it's often called the voice box. However, it actually has three functions. One, It prevents food and liquids from entering the trachea. 2, it acts as an air passageway between the pharynx and trachea. And 3, it produces sound. The body at work. Air passing between the vocal cords during exhalation produces sound. Loudness depends upon the force of the air. The more forceful the air, the louder the sound. Only the vocal cords produce sound. However, the pharynx, oral cavity, tongue, and lips shape the sounds to form words. High-pitched sounds result when the cords are relatively taut. More relaxed cords produce lower-pitched sounds, and vocal cords in adult males are usually larger and thicker and vibrate more slowly, producing lower-pitched sounds than in females. Question: what is the function of the nasopharynx? A, to filter dust. B, to warm and moisten inspired air. C, to provide openings for eustachian tubes. Or D, to contain the olfactory receptors for sense of smell. The answer is C. Rationale: filter dust, warm and moisten inspired air, and contain olfactory receptors are all functions of the nasal cavity. So the nasopharynx is for the eustachian tubes. The lower respiratory tract consists of the trachea, bronchi, and lungs. Okay, I'm on page 340. The trachea and bronchi distribute air to the interior of the lungs. Deep within the lungs is where the gas exchange occurs. Fast fact: the trachea and the two bronchi, with their many branches, resemble an inverted tree, and that's why it's often called the bronchial tree. The trachea, lying just below the front of the esophagus, the trachea is a rigid tube about 4.5 inches long and 1 inch wide. C-shaped rings of cartilage encircle the trachea to reinforce it and keep it from collapsing during inhalation. The open part of the C faces posteriorly, giving the esophagus room to expand during swallowing. The trachea extends from the larynx to a cartilaginous ring called the carina. At the carina, the trachea branches into two primary bronchi. Like the trachea, the primary bronchi are supported by C-shaped rings of cartilage. All of the divisions of the bronchial tree also consist of elastic connective tissue. The right bronchus is slightly wider and more vertical than the left, making this the most likely location for aspirated or inhaled food particles and small objects to lodge. Immediately after entering the lungs, the primary bronchi branch into the secondary bronchi, one for each of the lung's lobes. Since the left lung consists of 2 lobes, it has 2 secondary bronchi. The right lung has 3 lobes, so it has 3 bronchi. Secondary bronchi branch into smaller tertiary bronchi. The cartilaginous rings around the bronchi become irregular and disappear entirely in the smaller bronchioles. Tertiary bronchi continue to branch, resulting in very small airways called bronchioles, less than 1 millimeter wide and lacking any supportive cartilage. Bronchioles divide further to form thin-walled passages called alveolar ducts. Alveolar ducts throughout the lungs terminate in clusters of alveoli called alveolar sacs, the primary structures for gas exchange. Page 341, alveoli. The lung passages all exist to serve the alveoli because it's within the alveoli that the gas exchange occurs. and it's estimated that the lungs contain 300 million alveoli. The alveoli are wrapped in a fine mesh of capillaries. The extremely thin walls of the alveoli and the closeness of the capillaries allow for efficient gas exchange. The exchange of air occurs through what's called the respiratory membrane, which consists of the alveolar epithelium, the capillary endothelium, and their joined basement membranes. For gas to enter and leave a cell, it must be dissolved in a liquid. Therefore, inside of each alveolus is coated with a thin layer of fluid. This fluid contains surfactant, a substance that helps reduce surface tension, the force of attraction between water molecules, to keep the alveolus from collapsing as air moves in and out during respiration. For more information, see alveolar surface tension in this chapter. So as a side note, the way I like to think of this is that this surfactant is going to keep everything in your lungs moist so it doesn't dry out, because if it does dry out, it's not going to work. Which you would think, being in the lungs where there's a lot of air, it could dry out. But the surfactant is going to keep that, help maintain that layer that's needed, a thin layer of fluid so that it won't collapse. And also to keep your alveoli open in healthy people, it's a good idea to take some really deep breaths. Okay, I'm going to read the body at work on the bottom of page 341. A large portion of the membrane lining the bronchial tree is covered with a protective layer of mucus, which serves to purify the air entering the respiratory tract. This cleansing mucus moves up from the lower portion of the bronchial tree toward the pharynx, propelled along by millions of hair-like cilia that line the respiratory mucosa. The cilia beat in one direction, upward, so that the mucus will move towards the pharynx. Cigarette smoking paralyzes these cilia. As a result, mucus accumulates in the lower portions of the bronchial tree, causing the typical smoker's cough as the lungs attempt to rid themselves of the excess mucus. Fast fact: infants born before 28 weeks gestation commonly lack surfactant. Without surfactant, surface tension restricts alveolar expansion during inspiration and causes alveolar collapse during expiration. That's why neonates often develop respiratory distress syndrome and require administration of artificial surfactant. Lungs. The lungs fill the pleural cavity. They extend from just above the clavicles to the diaphragm and lie against the anterior and posterior ribs. The medial portion of each lung is concave to allow room for the heart and great vessels. The primary bronchi and pulmonary blood vessels enter each lung through an opening on the lung's medial surface called the hilum. Right lung. The right lung is shorter and broader and larger than the left. It has 3 lobes: the superior, middle, and inferior lobe. Handles 55% of the gas exchange. The right lung contains 2 fissures, the horizontal fissure and the oblique fissure that are separating those lobes. The top or apex of each lung extends about 1/2 inch above each clavicle. Left lung. Because the heart extends toward the left lung only has 2 lobes, the superior and inferior. It handles 45% of gas exchange and contains 1 fissure, oblique fissure. The base of each lung rests on the diaphragm. Life lesson: asthma. Asthma is the most common chronic illness in children. What's more, the number of people afflicted with asthma is on the rise. According to the Centers for Disease Control, about 8% of adults and over 9% of all children in the United States have asthma. Typically, when someone with asthma is exposed to an allergen or other respiratory irritant, such as dust or fumes, the bands of muscles surrounding the bronchioles constrict and spasm. This narrows the airway, triggering coughing and wheezing, sometimes severe, as the person struggles to breathe. Inflammation in the airways also causes excessive production of thick, sticky mucus that further clogs the airways. Airway obstruction can become severe enough to cause suffocation and death. Treatment involves dilating the airways through the administration of epinephrine and beta-adrenergic stimulants. Also, anti-inflammatory medications and inhaled corticosteroids are often prescribed to treat inflammation and minimize scarring. As a side note, I think if everybody keeps wearing their masks, that we will have fewer cases of asthma. But that's just my opinion. Okay, the next page is 343, which shows the pleura. A serous membrane, the visceral pleura, covers the surface of the lungs, extending into the fissures. The parietal pleura lines the entire thoracic cavity, and the space between the visceral and the parietal pleura is called the pleural cavity. The pleural cavity is only a potential space. The two membranes are normally separated only by a film of slippery pleural fluid. The fluid in the pleural cavity serves two purposes. It lubricates the pleural surfaces, allowing the two surfaces to glide painlessly against each other as the lungs expand and contract. Because the pressure in the pleural cavity is lower than atmospheric pressure, it creates a pressure gradient that assists with lung inflation. Life lesson: changes with aging. As the body ages, numerous changes occur in the respiratory system, all leading to a general reduction in respiratory efficiency. Here are a few of those changes: decreased mobility of the chest wall, increased lung rigidity, decreased number and dilation of alveoli, weakened respiratory muscles, and reduced volume of protective respiratory fluids. These changes reduce an older person's ability to perform vigorous exercise. They also lead to an increased risk for developing pneumonia following a bacterial or viral illness. In addition, these changes can compound the effects of heart and lung diseases. Question: inhaled food or foreign objects are most likely to lodge in which part of the respiratory system? This is an important question that I think will appear on an exam or a test, either the exit exam, possibly the NCLEX, or another exam. This is going to be important also for us to know when we're wondering, has somebody possibly suffered from aspirating something? So we need to know where that might land in case we are looking maybe at an x-ray or something. So is it the pharynx? No, because that's not in the lungs where we expect it to go. Is it the right bronchus, the left bronchus, or the bronchioles? Okay, so the answer is B, the right bronchus. And the right bronchus is slightly wider and more vertical than the left, making it the most likely location for aspirated objects to lodge, which makes sense because on the left side, everything is a little more crowded because the heart is there. So on the right side, we've got the three lobes. It is wider, and there's just more space there because it's not sharing that space with another organ like the heart. Okay, so um, pulmonary ventilation, page 344. Pulmonary ventilation is simply breathing, the repetitive process of inhaling called inspiration and exhaling called expiration. Both actions depend on the function of respiratory muscles and a difference between the air pressure within the lungs and the air pressure outside the body. One inspiration and one expiration comprise one respiratory cycle. Fast fact, in adults, normal respiratory rates range from 12 to 20 breaths per minute. Respiratory muscles. The lungs depend on the skeletal muscles of the trunk, especially the diaphragm and the intercostal muscles, to expand and contract to create airflow. The main muscle responsible for pulmonary ventilation is the diaphragm, the dome-shaped muscle separating the thoracic and abdominal cavities. Inspiration. The external intercostal muscles pull the ribs upward and outward, widening the thoracic cavity. The internal intercostals help elevate the ribs. The diaphragm contracts, flattens, and drops, pressing the abdominal organs downward and enlarging the thoracic cavity. Air rushes in to equalize pressure. Expiration. The intercostal muscles relax, pulling the ribs downward. The diaphragm relaxes, bulging upward and pressing against the base of the lungs, reducing the size of the thoracic cavity, and air is pushed out of the lungs. Accessory muscles of respiration. During times of forced or labored breathing, additional muscles called accessory muscles of respiration join in to assist with breathing. For example, during deep inspiration, muscles of the neck, the sternocleidomastoids and scalenes, and the chest, the pectoralis minor, contract to help elevate the chest. See the red arrows in the figure. During forced expiration, such as when singing or shouting, the rectus abdominis and external abdominal obliques contract to pull down the ribs and sternum, further reducing chest size and expelling air more rapidly. See the blue arrows in the figure. Body at work. People having difficulty breathing may depend heavily on accessory muscles to breathe. For example, in emphysema, lungs lose their elasticity and exhaling is no longer a passive process. Patients must use their accessory muscles to exhale, making exhaling an active, exhausting process. In other patients, the use of accessory muscles can indicate acute respiratory distress, signaling a medical emergency. Neural control of breathing. Unlike cardiac muscle, which contains intrinsic pacemakers, the muscles used for breathing are skeletal muscles, and skeletal muscles require nervous system stimulation to contract. Although a variety of factors affect the rate and rhythm of breathing, the respiratory centers responsible for automatic, unconscious breathing reside in the medulla and pons, part of the brainstem. The medulla contains two interconnected centers that control breathing, the inspiratory center and the expiratory center. The inspiratory center is the primary center. It controls inspiration and indirectly expiration as well. Here is how it works. Number one, the inspiratory center sends impulses to the intercostal muscles via the intercostal nerves and to the diaphragm via the phrenic nerves. The inspiratory muscles contract, causing inhalation. Nerve output then ceases abruptly, causing the inspiratory muscles to relax. The elastic recoil of the thoracic cage produces exhalation. Although the medulla is the main breathing center, the pons contains two centers that can influence basic breathing rhythm. The apnostic center stimulates the inspiratory center to increase the length and depth of inspiration. The pneumotaxic center inhibits both the apnostic center and the inspiratory center, and this contributes to a normal breathing rhythm and prevents overinflation of the lungs. When more forceful exhalations are needed, such as during exercise, the expiratory center sends the impulses to the abdominal and other accessory muscles. Body at work. The cerebral cortex allows you to voluntarily change your rate or rhythm, such as to sing or blow out a candle, or even to hold your breath. However, when you hold your breath, CO2 isn't expelled through breathing, and the CO2 level in the blood rises. Carbon dioxide, or CO2, is a powerful respiratory stimulant. When the CO2 rises to a certain level, the respiratory centers override your voluntary action and breathing resumes. Variations in breathing. Despite neural input, breathing patterns don't remain constant. Respiratory rate and rhythm vary with pain, emotion such as fear, anger, or anxiety, exercise, and changes in the body's physical state. These variations occur because the respiratory centers receive input from a number of sensory receptors throughout the body, alerting it to the body's changing needs. Fast fact, carbon dioxide, not oxygen, is the primary regulator of respiration. That's because carbon dioxide easily crosses the blood-brain barrier. That is possibly going to be on a test. So you need to know that it is the carbon dioxide levels that are the primary regulators of our breathing and our respiration. Factors that influence breathing are shown here. Oxygen levels, pH, stretch, pain and emotion, as well as irritants. Question: what is the main muscle responsible for pulmonary ventilation? Is it your abdominals, your external intercostals, your diaphragm, or your internal intercostals? I'm going to say the diaphragm. Yes, that's correct, the diaphragm. And the rationale, whereas the intercostals are used in the respiratory process, the diaphragm is the main muscle for pulmonary ventilation. The abdominal muscles are accessory muscles of ventilation. Okay, page 347, pressure and airflow. Air moves in and out of the lungs for the same reason that blood flows, because of a pressure gradient. The pressure that drives respiration is atmospheric pressure, the weight of the air around us. When pressure within the lungs drops lower than atmospheric pressure, air flows from the area of higher pressure, the air outside the body, to an area of lower pressure, the lungs. This is inspiration. When pressure within the lungs rises above atmospheric pressure, air flows out of the lungs, expiration, until the two pressures equalize. Whereas inspiration is an active process requiring the use of muscles, normal expiration is a passive process resulting from the recoil of healthy lungs. Inspiration. The intercostal muscles contract, pulling the ribs up and out. The diaphragm contracts and moves downward. This enlarges the chest cavity in all directions. The lungs expand along with the chest because of the two layers of the pleura. The parietal pleura is firmly attached to the ribs, and the visceral pleura covers the lungs. Although not attached to each other, the thin film of fluid between the two pleura causes them to cling together like two sheets of wet paper. Furthermore, the potential space between the two pleura maintains a pressure slightly less than atmospheric pressure, negative pressure. This is the intrapleural pressure. When the ribs expand and the parietal pleura pulls away, intrapleural pressure becomes even more negative. This has a suction-like effect, causing the visceral pleura to cling even tighter to the parietal pleura. The visceral pleura follows the parietal pleura, pulling the lung along with it. When the lungs expand, the volume of air in the lungs spreads throughout the enlarging space. This causes the pressure within the bronchi and alveoli to drop. This is the intrapulmonic pressure. When the intrapulmonic pressure drops lower than the atmospheric pressure, air flows down the pressure gradient into the lungs. Expiration. The diaphragm and external intercostal muscles relax, and the thoracic cage springs back to its original size. The lungs are compressed by the thoracic cage. Intrapulmonary pressure rises. Air flows down the pressure gradient and out of the lungs. That makes sense. The law of physics called Boyle's law explains why intrapulmonic pressure drops as the lungs expand. Boyle's law states, at a constant temperature, the pressure of a given quantity of gas is inversely proportional to its volume. In other words, in a given volume of gas will exert more pressure in a smaller space than it will in a larger space. To illustrate, imagine tying off the end of a large plastic bag. The air in the bag would cause the bag to balloon slightly, but the air would still be soft to touch. The air inside the bag would have a low pressure. Now imagine twisting the end of the bag, making the volume of the bag smaller. This would force the air in the bag into a smaller space, and the bag would become firm to touch, exhibiting a higher pressure. If you continued to twist, making the bag even smaller, the pressure could become great enough to pop the bag. Question: when pressure in the lungs drops lower than atmospheric pressure, what occurs? Air flows out, air flows in, or a pneumothorax forms, or the bronchioles constrict. I'm going to say B, the air flows into the lungs. Air flows from an area of higher to lower pressure. Therefore, air flows out of the lungs when the pressure in the lungs is higher than atmospheric pressure. Life lesson, page 348, pneumothorax. If the thoracic wall is punctured, air from the atmosphere will rush into the pleural cavity, transforming what is normally a potential space into a space filled with air. As a result, the negative pressure that characterizes the pleural cavity is lost, and the lung recoils and collapses. This is called a pneumothorax. Air can also enter the pleural space when a weakened or diseased alveolus ruptures. This causes a disruption in the visceral pleura, and air from the lung enters the pleural cavity, again resulting in a pneumothorax. Factors affecting airflow. Effective pulmonary ventilation depends on several factors. Two particularly important factors are pulmonary compliance and alveolar surface tension. Pulmonary compliance refers to the elasticity of lung tissue. Ventilation can't occur unless the lungs and thorax can stretch and, just as important, recoil. Some diseases, such as tuberculosis or black lung disease, cause scarring, which makes the lungs stiffer or less compliant. The lungs have difficulty expanding and ventilation is impaired. Alveolar surface tension. The inner surface of each alveolus is covered with a thin film of water. The water is necessary for gas exchange. However, water molecules are also electrically attracted to each other, just like weak magnets. Left alone, the water molecules inside the alveolus will move toward each other, creating a force that will collapse the alveoli. If the alveoli collapse, gas exchange can't occur. To avoid this problem, alveolar cells secrete surfactant, a lipoprotein that disrupts the electrical attraction between the water molecules, and this lowers the surface tension and prevents alveolar collapse. That's a very good explanation of that. Life lesson, emphysema. Emphysema is a progressive lung disease in which lung tissue surrounding alveoli is destroyed. This leaves alveoli unsupported, allowing them to enlarge and eventually rupture. Alveolar walls fuse into large irregular spaces that offer less area available for gas exchange. The alveoli also lose elasticity and the ability to recoil. Consequently, air becomes trapped in the lungs. Over time, the trapped air causes the diameter of the chest to enlarge, and the chest assumes the shape of a barrel. A person with emphysema is often said to be barrel-chested. Persons with emphysema must work to exhale. They can expand 3 to 4 times the normal amount of, expend 3 to times the normal amount of energy just to breathe. So they are going to need more calories to support that energy demand. Okay, measurements of ventilation, page 349. Measuring lung capacity can provide information about the health of a person's lungs. This information is usually obtained by having the person breathe through a device called a spirometer. The values shown in the following spirographic record are typical for a healthy young adult, which I guess it's not shown on this PowerPoint, but it is on page 349. The amount of air, well, I'm not going to read that part about the tidal volume, but they explain inspiratory, reserve, expiratory, and so forth. With every breath, about 150 milliliters, which is 5 ounces, because 30 milliliters is 1 ounce, of air remains in the conducting airways. Since this air doesn't reach the alveoli, it can't participate in gas exchange. The air is said to be in the anatomical dead space, in the passageways instead of the alveoli. Anatomical dead space occurs normally as the air makes its way to the alveoli. Physiological dead space includes all of the air in conducting airways, the anatomical dead space, plus the air in any alveoli that are poorly perfused and therefore less efficient in gas exchange. Certain diseases cause portions of the lungs to be poorly infused, leading to increased physiological dead space. The body at work. Vital capacity depends on several factors, including an individual's size, posture, overall health. In general, a tall person has larger lungs and therefore a larger vital capacity than does a short person. Also, standing erect increases vital capacity, while slouching or lying down decreases it. So you need to sit up straight so you can maximize your respiratory capacity. Certain diseases also affect vital capacity. For example, excess fluid in the abdomen or pleura encroaches upon the space occupied by the lungs, diminishing vital capacity. Congestive heart failure causes blood to back up in the lungs, filling alveolar airspace and decreasing vital capacity. On the other hand, exercise programs and yoga have been shown to increase vital capacity. I think I'm going to go back and read these definitions because it's on the slide here. So the amount of air inhaled and exhaled during quiet breathing is known as tidal volume. After taking a normal breath, it's still possible to inhale even more air. This amount of air, inhaled using maximum effort after a normal inspiration, is called the inspiratory reserve volume. Likewise, after a normal expiration, it's possible to exhale even more air. The amount of air that can be exhaled after a normal expiration by using maximum effort is called the expiratory reserve volume. Even after a forced expiration, about 1,300 milliliters of air remains in the lungs, called the residual volume. This air ensures that gas exchange continues even between breaths. The amount of air that can be inhaled and exhaled with the deepest possible breath is called the vital capacity. Vital capacity is the tidal volume combined with the inspiratory and expiratory reserve volumes. Total lung capacity is the maximum amount of air that lungs can contain. The vital capacity plus the residual volume. Variations in respiratory rhythm. A variety of conditions, including exercise, anxiety, and various disease states, influence respiratory rate and rhythm. The following table lists the names for common variations in breathing. So there's apnea, which is a temporary cessation of breathing. Biot's respirations. These are abrupt, irregular breathing patterns in which periods of apnea alternate with periods of breathing that are consistent in rate and depth, often results from increased intracranial pressure. Cheyne-Stokes respirations. These are important because this is common when people are dying. Cyclical breathing pattern that begins with an increase in rate and depth of respirations, a crescendo effect, followed by a gradual decrease in the rate and depth of inspiration, decrescendo effect, culminating in a short period of apnea before repeating, often seen in terminally ill or brain-damaged adults. Dyspnea is labored or difficult breathing. Eupnea is relaxed, quiet breathing. Hyperventilation is increased rate of respirations resulting in lowered blood levels of carbon dioxide, and it often results from anxiety. Hypoventilation, reduced rate and depth of respirations resulting in increased blood levels of carbon dioxide. And then cosmal respirations, these are very deep, grasping respirations associated with diabetic ketoacidosis. You're also probably going to smell a fruity odor on these patients with the cosmal respirations. Orthopnea is labored breathing that occurs when a person is lying flat, but improves when standing or sitting up a classic symptom of left ventricular heart failure, and tachypnea is rapid breathing. Okay, fast fact, obesity involves a buildup of adipose tissue around the rib cage and abdomen. This extra load reduces all lung volumes, thus interfering with optimal respiratory function. Gas exchange. The goal of respiration is the delivery of oxygen to the organs and tissues of the body and the removal of carbon dioxide. This exchange of gases, both in the lungs and in the tissues of the body, depends on differences in pressure. The air we breathe has a pressure of 760 mmHg. This is known as total atmospheric pressure. The atmosphere consists of about 78% nitrogen, 21% oxygen, and about 1% other gases, of which about 0.03% is carbon dioxide. Each one of these gases contributes to the total atmospheric pressure. The contribution of a single gas in any mixture of gases is called partial pressure. A gas's partial pressure is symbolized by the letter P followed by the formula for the gas, such as PCO2. So that would be your partial pressure of carbon dioxide. And the other part would be oxygen, and the other part would be nitrogen. So that makes sense. The partial pressure of a gas directly relates to its concentration in a mixture. For example, oxygen contributes approximately 21% of atmospheric air. To determine its partial pressure, multiply 0.21, the percentage of oxygen, by 760, the total pressure of the atmosphere. The resulting number is 159.6. That's the partial pressure of oxygen in the air we breathe. Life lesson, abdominal thrusts. Abdominal thrusts, formerly called the Heimlich maneuver, is an effective maneuver for dislodging a foreign object in someone who is choking. The maneuver uses the residual volume of air already in the lungs to expel an object in the trachea. If someone appears to be choking, always ask, "Can you speak?" Someone with an obstructed airway won't be able to talk even though he's conscious. Remember, the air has to pass between the vocal cords for someone to talk. If the airway is indeed obstructed, follow these steps. 1. Stand or kneel behind the person who is choking. Make a fist with one hand and wrap your arm around the person's waist. Place your fist thumb inward in the person's abdomen, above the navel and below the rib cage. Wrap your other arm around the person from the other side, placing your other hand over your fist. Use your outer hand to force your fist into the abdomen. Make quick, hard movements inward and upward to force the air out of the person's lungs. Repeat the maneuver several times if necessary to dislodge the object. Process of gas exchange. The partial pressures of oxygen and carbon dioxide vary between the air we breathe, the alveoli, arterial blood, and venous blood. It's these variations in pressure that allow the body to absorb oxygen and expel carbon dioxide. The key point to remember is that gas diffuses from an area of higher pressure to an area of lower pressure until the pressures are equalized. Follow the path of blood along the circulatory route, noting the differences in the partial pressures of oxygen and carbon dioxide. And the book says there's an animation to go along with this. They're showing a swimmer here. Inspired air has a PO2 of 159 and a PCO2 of 0.3. When it arrives at the alveoli, air has a PO2 of 104 and a PCO2 of 40. On the other side of the alveoli's thin membrane are pulmonary capillaries containing blood with a PO2 of 40 and a PCO2 of 46. The differences in partial pressures of O2 and CO2 on either side of the respiratory membrane causes O2 to move out of the alveoli and into the capillaries, and CO2 to move out of the capillaries into the alveoli. In other words, the red blood cells in the capillaries unload CO2 and load oxygen. The CO2 is later exhaled through the lungs. Blood in the capillaries now has a PO2 of 100 and a PCO2 of 40. This oxygen-enriched blood travels to the to the heart's left ventricle, where it's pumped to the body's tissues. Meanwhile, the cells in the body's tissues have been using oxygen for energy production and producing CO2 as a byproduct. The fluid surrounding the cells has a PO2 of 40 and a PCO2 of 46. When the blood from the left ventricle with a PO2 of 100 arrives at the tissues with a PO2 of 40, the oxygen diffuses out of the blood and into the tissues. Simultaneously, carbon dioxide diffuses from the tissues, PCO2 of 46, and into the blood, PCO2 of 40. Once it has released oxygen to the tissues and absorbed CO2, the capillary blood has a PO2 of 40 and a PCO2 of 46. Systemic capillaries carry this oxygen-depleted blood away from the tissues and toward the heart's right ventricle, where it will be pumped back into the lungs. The body at work. Optimal gas exchange obviously depends upon a number of factors, including those listed in the table below. A disruption in any one of these factors can profoundly affect oxygenation. Factors necessary for oxygenation. Pressure gradient between the oxygen in the alveolar air and the oxygen in incoming pulmonary blood. Potential disruption at high altitudes. The partial pressure of oxygen in inspired air is less than at sea level. As a result, alveolar PO2 is decreased and less oxygen enters the blood. So remember that. That's going to be at high altitudes. There's something to consider with our patients. Adequate alveolar surface area is also another factor necessary for oxygenation, and certain disorders such as emphysema, pneumothorax, and surfactant disorders decrease the functional surface area of the lung, and less area is available for gas diffusion and blood oxygen levels decline. There also needs to be an adequate respiratory rate. So for gas diffusion to occur, alveoli must receive a steady supply of oxygen through inspired air. Anything that decreases the respiratory rate, such as the narcotic morphine, lessens the amount of oxygen entering the blood. How the blood transports gases. The process of carrying gases from the alveoli to the tissues and back is known as gas transport. Transport of oxygen. Of the oxygen entering the body, only 1.5% is dissolved in blood plasma. Here's what happens to the remaining 98.5% of oxygen. In the lungs, the oxygen forms a weak bond with the iron portion of hemoglobin, creating oxyhemoglobin. Oxyhemoglobin travels through the circulatory system to tissue cells. Once there, the difference in pH between the arterial and venous blood is enough to break the bond between the oxygen and the hemoglobin. The oxygen is then released to the tissues. Transport of carbon dioxide. Carbon dioxide is transported from the tissues to the lungs in 3 ways. About 10% is dissolved in the plasma. Another 20% is bound to hemoglobin, forming carbaminohemoglobin. Hemoglobin can transport both oxygen and carbon dioxide at the same time because they bind to different sites on the hemoglobin molecule. Number 3, the vast majority, about 70%, is carried in the form of bicarbonate ions, HCO3. This occurs because when CO2, carbon dioxide, dissolves in plasma, it reacts with the water in the plasma to form carbonic acid. Carbonic acid then dissociates into bicarbonate and hydrogen ions. Fast fact: hemoglobin has a stronger affinity for carbon monoxide than it does for oxygen. That's why exposure to carbon monoxide can be deadly. Once bound to carbon monoxide, hemoglobin can't transport oxygen. Okay, so we finished reading this chapter, chapter 17, respiratory system, and we are going to test our knowledge. So number 1 is, which of the following is a function of the nasopharynx? We already had that question in our PowerPoint. And let me see if I can find it again on the slides. There it is. And we remember that the answer is C, to provide openings for the right and left eustachian tubes. So the nasopharynx, part of the pharynx, contains openings for the right and left eustachian tubes. The nasal cavity contains cilia that filter dust and foreign particles from inspired air. The mucus of the nasal cavity warms and moistens the inspired air, and the branches of the olfactory nerves responsible for the sense of smell penetrate the upper nasal cavity and lead to the brain. The answer is C for number 1 on page 355. Number 2, which structure is responsible for directing food and liquids into the esophagus during swallowing? Is it the glottis, the epiglottis, the Adam's apple, or the conchae? The answer is B, the epiglottis, okay, because A, the glottis is the space between the vocal cords. And the Adam's apple, also called the thyroid cartilage, is the largest piece of cartilage forming the trachea and has no role in swallowing. And conchae are bones in the lateral walls of the nasal cavity. The answer to number 2 is B, the epiglottis. Number 3, what purpose do the cartilaginous rings around the trachea serve? A, keep the trachea from collapsing during inhalation. B, attach the trachea firmly to the esophagus. C, protect the trachea from trauma. And D, they serve no purpose. So the answer is A, tracheal cartilage is C-shaped with the opening in the posterior region, which allows the esophagus to expand during swallowing, but the two structures are not attached to each other, and the primary purpose of the cartilage is not for protection. Number 4 is, inhaled food or foreign objects are most likely to lodge in which part of the respiratory system? Is it A, the pharynx, B, the right bronchus, C, the left bronchus, or D, the bronchioles? And it's B, the right bronchus, because there's more space on the right because it's not crowded by the heart. So the right bronchus is slightly wider and more vertical than the left, making it the most likely location for aspirated or inhaled food particles and small objects to lodge. Number 5, what is the purpose of surfactant? A, to facilitate in the diffusion of oxygen across the respiratory membrane. To transport oxygen to the alveoli. C, to purify the air entering the respiratory tract. Or D, keep the alveoli from collapsing. So a surfactant is actually B. It's to keep the alveoli from collapsing because it's a substance that helps reduce surface tension, the force of attraction between the water molecules, to keep the alveolus from collapsing as the air moves in and out during respiration. It does not facilitate the diffusion of oxygen. Hemoglobin is the primary transporter of oxygen in the bloodstream, and surfactant has no role in the purification of the air in the respiratory tract. 6. What is one of the purposes of the fluid in the pleural cavity? Is it A, to lubricate the pleural surfaces to allow them to glide painlessly during lung expansion and contraction? B, to warm and moisten lung tissue. C, prevent bacteria from entering lung tissue. Or D, to assist in the diffusion of oxygen across the respiratory membrane? And the answer is A, to lubricate the pleural surfaces. So the fluid in the pleural cavity lubricates the pleural surfaces, allowing the two surfaces to glide painlessly against each other as the lungs expand and contract. It also creates a pressure gradient that assists in lung inflation. None of the other answers is correct. Number 7, the main muscle responsible for pulmonary ventilation is A, the abdominals, B, the external intercostals, C, the diaphragm, or D, the internal intercostals. And in this case, the main muscle is definitely the diaphragm, which is C, because the internal and external intercostal muscles are used in the respiratory process. However, the diaphragm is the main muscle responsible for pulmonary ventilation, and the abdominal muscles are accessory, not primary muscles of respiration. Number 8, which gas is the primary regulator of respiration? Is it oxygen, carbon dioxide, nitrogen, or bicarbonate? And the answer is carbon dioxide. So this is really important for patients that might be on an oxygen generator or are having other lung issues. We need to remember that carbon dioxide, not oxygen, is the primary regulator of respiration. Nitrogen is a major component of the atmosphere, but it is not involved in respiration. Carbon dioxide is transported through the bloodstream in the form of bicarbonate, but bicarbonate does not have a role in respiration. Number 9, when the pressure in the lungs drops lower than atmospheric pressure, what occurs? Okay, what occurs? Is it A, that air flows out of the lungs, or B, it flows into the lungs, or C, a pneumothorax forms, or D, the bronchioles constrict? So if the pressure in the lungs is lower than atmospheric pressure, then it's going to try to equalize, and therefore it's going to fill with air. So the answer would be B. Air flows from an area of higher to lower pressure. Therefore, air flows out of the lungs when the pressure in the lungs is higher than atmospheric pressure. So a pneumothorax results when air accumulates in the pleural space, which it's not supposed to do. Asthma is a condition in which bronchioles spasm and constrict, causing respiratory distress, because all that constriction can prevent the proper flow of the gases that we need. Number 10, the primary way oxygen is transported in the blood is A, in the form of bicarbonate, B, in the form of carbinohemoglobin, C, in the form of oxyhemoglobin, or D, dissolved in plasma. And the answer for the primary way that oxygen is transported is C, in the form of oxyhemoglobin. So carbaminohemoglobin and bicarbonate are two forms used to transport carbon dioxide, not oxygen. Only 1.5% of the oxygen entering the body is dissolved in plasma, so we're not going to consider that a primary way to transport it, although it does have some. 98.5% travels through the circulatory system in the form of oxyhemoglobin to reach all the tissues. Number 11, normal aging typically causes which of the following respiratory system changes? A, an increased number of alveoli. I doubt that. B, increased volume of protective respiratory fluids. I doubt that. C, decreased lung rigidity. No, I wish we knew a way to decrease lung rigidity. D, decreased mobility of the chest wall. In other words, increased rigidity. And that is the answer. Because as we age, changes in the respiratory system tend to occur in the body as it ages, including a decreased number and dilation of alveoli, a reduced volume of protective respiratory fluids, increased lung rigidity, and decreased mobility of the chest wall. Thank you for your time. That is all for this recording. Hope it helped.